Hi, I'm going to talk about the source of floating electrolytes, vasopressin antagonists. First, I'm gonna tell you the definition. Electrolyte disorders result in an imbalance of minerals in the body. For the body to function properly, certain minerals need to be maintained in an even balance. Otherwise, vital body systems such as the muscles and brain can be negatively affected. Electrolytes refer to minerals that include calcium, chloride, magnesium, phosphate, potassium, and sodium. They are present in your blood, body fluids, and urine. They are ingested with food, drink, and medicines and supplements as well. Anyone can develop an electrolyte disorder. Some people are more likely to because of their personal health history. For example, people with kidney disease might develop several electrolyte disorders. This is because their kidneys are not able to filter their minerals as well as healthy kidneys. Other conditions that increase a person's risk include alcoholism and cirrhosis of the liver, congestive heart failure, eating disorder, kidney disease, trauma such as severe burns or broken bones, thyroid and parathyroid disorders.
This program will discuss imbalances in some of the main electrolytes in the body. The electrolyte balance in the body's fluids is absolutely crucial to many body processes, and any imbalances can cause serious disorders and can even be life-threatening. As described in an earlier program, the fluids in the body are filled with dissolved salts and minerals that take on plus or minus electrical charges and are called ions or electrolytes. The common electrolytes sodium, potassium, and calcium take on positive charges in a fluid and are called cations, and chloride, bicarbonate, and phosphate take on negative charges and are called anions. The concentrations and charges of these electrolytes have a lot to do with how fluids move through the body and how they pass through the membranes into and out of cells and blood vessels. Osmosis, diffusion, and active transport are all processes of fluid transfer through membranes that are dependent on the concentrations of electrolytes. Imbalances in electrolytes can disrupt this flow of fluids and cause many pathological conditions. Body's cells feed themselves, rid themselves of wastes, and send and receive chemical substances from all around the body. Much of this complex fluid transportation network is controlled by electrolytes and how they influence the movement of fluids through membranes.
Ample evidence is available to implicate vasopressin, a small polypeptide that is synthesized in the hypothalamus and secreted from the posterior pituitary, in the pathogenesis of most hyponatremic disorders. As the most common electrolyte disorder, hyponatremia is consistently associated with increased mortality and morbidity. The treatment of hyponatremia has been plagued by a paucity of controlled studies and by a lack of reliable and safe approaches. This review summarizes the salient discoveries that culminated in the development of these drugs and focuses on what vasopressin antagonists do and do not do, the side effects, emerging safety concerns, and important gaps in data.
Arginine vasopressin, or AVP, plays a critical role in maintaining the balance between salt and water. AVP is also known as vasopressin or antidiuretic hormone. AVP is formed in the hypothalamus and transported to the pituitary gland for storage. Secretion of AVP is stimulated when a deficiency of body fluid is sensed, such as an increase in plasma osmolality or decrease in arterial volume. Other AVP stimuli include medications such as diuretics and antidepressants, nausea, pulmonary infections, and mechanical ventilation. AVP acts at specific receptor sites to regulate salt and water balance. The V1A receptor is located primarily in arterial smooth muscles, and V2 receptors are located on the renal collecting duct cells. In the smooth muscle cells of arteries, AVP binds to the V1A receptor. This causes smooth muscle contraction and arteriolar vasoconstriction in an attempt to maintain perfusion pressure. AVP binds to the V2 receptor in the renal tubular cell of the collecting duct. This stimulates increased intracellular cyclic AMP and activation of protein kinase A. Phosphorylation of the microtubular subunits results in aggregation to form aquaporins, which are then inserted into the luminal membrane. Water enters through the aquaporins on the luminal side of the renal tubule and exits passively on the basolateral side into the capillary space. The action of AVP at the V2 receptor helps maintain plasma osmolality in the normal range by increasing free water reabsorption. When plasma AVP is low or undetectable, the kidney excretes solute-free water. Fluid coming from the proximal diluting segment of the nephron passes through the distal segment and collecting tubules without significant modification. As a consequence, the urine is dilute or hypoosmolar to plasma, and its volume and flow rate is high. Aquaresis is the increased excretion of water by the kidney without an increase in sodium excretion. AVP receptor antagonists, such as vapopressin, conivaptan hydrochloride injection, act primarily by V2 receptor antagonism of AVP in renal collecting ducts. The effect of blocking this receptor results in the electrolyte-sparing excretion of free water, or aquaresis. Disrupted AVP secretion frequently results in an imbalance of salt and body water. Increased AVP secretion leads to decreased free water excretion, resulting in water retention. When this causes an excess of body water relative to sodium content, the result is dilutional hyponatremia. In patients with euvolemic hyponatremia, the total body sodium is unchanged, and total body water is increased. However, there are no clinical signs of edema. Syndrome of inappropriate secretion of ADH is the most common cause of euvolemic hyponatremia. SIADH is seen when plasma levels of AVP are elevated at times when physiologic AVP secretion would normally be suppressed. Causes of this syndrome include CNS disorders such as subarachnoid hemorrhage, meningitis, and head trauma. Other causes of SIADH include pulmonary disorders such as pneumonia or carcinomas. Total body.
Most commonly, VRAs are used in the treatment of hyponatremia, especially in patients with congestive heart failure, liver cirrhosis, or SIADH. The mechanism of action of these vasopressin antagonists. Well, the investigators established the site on the receptor at which antagonists are likely to disrupt binding to the V1A21 and V222 receptors. Vasopressin binds at a superficial site, whereas antagonist penetrates deeply into the membrane, altering the ability of the agonist to bind to the receptor in the adjacent loop. This inhibition culminates in the prevention of the insertion of water channels into the apical membrane, which thereby inhibits the reabsorption of water and the generation of concentrated urine.
I'd like to talk the new diuretics for the treatment of the heart failure. And today I just touched on the two new inotropic diuretics, new diuretics. One is the vasopressin antagonist, and the other is the adenosine antagonist. As you know, as the other neurohumoral factors in heart failures, this slide shows the plasma vasopressin is increasing with the severity of the heart failure. The New York Heart Association class 4 in the plasma vasopressin is an increase. And vasopressin, another name is the antidiuretic hormone. They stimulate V1A receptors. These are the vasoconstriction and increase the afterwall. And V1A is the just like alpha stimulation of adrenergic stimulation, LV hypertrophy, or remodeling induced. However, V2 is the water retentions. So if we stimulate water retentions, then hyponatremia and heart failure is some serious problem. And this is also contribute to the increase in peril. So in that scheme, the inhibition of the alkaline vasopressin should be effective to reduce the afterload and also the to improvement of the hyponatremia in patients with heart failure. And this slide shows that even in the heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, hyponatremia is getting worse in the prognosis in both entity of the heart failure. Tolvaptan is the selective V2 receptor antagonist, and this shows the V2 receptors. And the tolvaptan here is the very closely fit the three-dimensional structure of the receptors. And here is the OPC 41061 in the tolvaptan. One side the tolvaptan V2 antagonist is worse is here. A second beam of the loop diuretics is action here. Thiazide is action here. Aldosterone is the action here in the correcting tubule. And tolvaptan and alkaline vasopressin is the acting here. And you can see the magnify this area. V2 receptors is located on the basolateral membrane. This is the vessel, and this is the principal cell, and this is a correcting tubule duct. And V2 receptor is located here. And if we stimulate V2 receptors, then it phosphorylates the aquaporin 2, and this is wrapped by the vesicles and recycling in the cell, and stimulation by the AVP by V2 receptors. So aquaporin moved to this luminal membrane and fixed into the as a water channel. That means the permeability of the water is increased, and water transferred inside. And further, through apocrine 3 or apocrine 4, this is the incorporated in the vessel. So the stimulation of V2 receptors is the increase the permeability for the water to reabsorption of the water is increased. So tolvaptan inhibited this V2 receptors. That means the absorption of water, free water, is inhibited by this drug.
Now the pros. Well, vasopressin antagonists are effective drugs that antagonize the hydrosmotic effects of vasopressin. Vatans increase urine flow and the excretion of electrolyte-free water without substantial changes in sodium or potassium excretion, leading to their designation as aquatic agents. Treatment with vasopressin antagonists consistently increases plasma sodium levels. On the other hand, the cons. Dependence on the excretion of free water makes the response to vasopressin antagonists too slow to benefit patients with hyponatremia who have several symptoms. Neither drug is effective in patients with advanced chronic kidney disease in stage 4 or 5. Furthermore, V1A receptor antagonists can cause hypotension in such patients. Well, vasopressin antagonists The most common adverse events of vasopressin antagonists are polyuria, urinary frequency, thirst, mouth dryness, constipation, and nausea. Issue applied in Ecuador. Few studies comparing vasopressin antagonists with alternative treatments for hyponatremia are available. In a small one-year crossover study involving 12 patients, increases in plasma sodium levels were similar among patients receiving tolvaptan and those receiving urea. To sum up, the conclusion. The advent of the use of vasopressin antagonists has provided physicians with a new means of increasing the plasma sodium level in patients with hyponatremia. These agents appear to offer substantial advantages over previously available therapies that have been shown to have limited efficacy and an acceptable side effect profile, or both. To ascertain whether such increases in the plasma sodium level have an effect on mortality and morbidity associated with hyponatremia is a challenge for the next decade.
This tolvaptan is a selective V2 receptor antagonist with aquaresis water secretion effects that increase water secretion but not electrolyte excretion. Studies in the United States, Europe, this is the Everest study, demonstrated the efficacy of dose titration from 15 to 30 to 60 milligram tolvaptan administered once daily in patients with hyponatremia. In Japan, the recommended dose is 15 milligram once daily. And while short-term benefit of tolvaptan have been demonstrated in clinical trial, long-term effect on the prognosis of the patient has not been shown in evidence. So the future studies should be investigated on long-term effect of tolvaptan in terms of mortality and morbidity. However, in Japan, this drug is indicated and Japanese PMDA accepted as a treatment of the volume overload in patients with heart failure. So 3 years we can use this diuretics to control the water control in patient with heart failure.